Welcome to the COBRA event of this month, and we're closing up June with a really exciting presentation from Ben Hallowell from the Rhode Island Department of Health, and some wonderful partnerships with colleagues at the COBRA. I'm Tracy Green. I'm the Deputy Director of the COBRA on Opioids and Overdose, and excited to have a presentation and some exchange from our speakers today. So I'm going to hand the Zoom microphone over to Francesca Baudouin and have her introduction, as well as of Ben and of course of herself. So thank you so much for coming.
Thank you so much, Tracy, and thank you all for coming this afternoon. My name is Francesca Baudouin. I am the Chair of Epidemiology at the Brown University School of Public Health. I am also trained as an emergency physician, currently practicing addiction medicine, and an investigator on some of the work that you're going to hear about today. But the real star of the show is my friend and colleague, Dr. Benjamin Hallowell. Ben is the team lead for the Substance Use Epidemiology program at the Rhode Island Department of Health. He received his MPH from the University of Connecticut in 2014, followed by doctoral training in epidemiology at the University of Georgia in 2017. Following that, he served as the Epidemic Intelligence Service Fellow at the Division of Viral Diseases at the CDC from 2018 to 2020. And then we were fortunate to get him up in Rhode Island, where in his role at the Rhode Island Department of Health, he is leading survey analytic projects and biostatistics for the prescription drug monitoring program. And for us, it's been such a pleasure to collaborate. And Dr. Hallowell has been very tremendous catalyst for an academic state partnership and improving our state's ability to respond to the opioid epidemic. So with that, Ben, I'm going to turn it over to you to take us through your talk. And then I think I will facilitate some Q&A at the end. But welcome.
Sounds good, and thanks for the introduction. Yeah, so a lot of familiar faces on the call today, so nice to see everyone. Here, I'll share my screen. Okay, hopefully that's coming up. All right. Let me just minimize this. All right, so good morning, everyone. Hope everyone's having a nice week so far. So as Francesca mentioned, my name is Ben Hallowell, and my talk today looks to see if demographic and prescription factors impact long-term buprenorphine treatment engagement. And first, I just want to acknowledge all the other collaborators who helped me, including Laura Chambers, Liz Samuels, and Francesca. So I'll go brief on this part because I know many of you are already familiar. But first, I just want to start with a little background on treatment for medications for opioid use disorder. So as everyone on this call knows, there's two primary treatments approved by the FDA for opioid use disorder: methadone and buprenorphine. The only main difference is that methadone has to be taken through direct observed therapy, while buprenorphine can be prescribed, dispensed at a pharmacy, and taken at home. And overall, they have relatively similar effectiveness in terms of treating opioid use disorder. From the health department, there's like two main issues with opioid use disorder treatment. And so the first one is, in 2020, an estimated 2.7 million individuals in the United States met the criteria for opioid use disorder. However, only about 278,000 had received medications for opioid use disorder in the last 12 months. So the first barrier is just getting people connected with care. And as opioid overdose fatalities have doubled between 2015 and 2020, linking people with opioid use disorder to treatment is now more important than ever. So it's important to connect individuals to care because long-term use of medications for opioid use disorder, such as buprenorphine, can help reduce the risk of fatal and non-fatal drug overdoses, can lower healthcare utilization costs, and can help individuals discontinue substances if they choose. Additionally, these impacts are often greatest when people can remain in long-term treatment. And so this brings us to the second issue. So unfortunately, even if individuals can initiate treatment, long-term treatment engagement is challenging. And generally, within the first few weeks of treatment, buprenorphine discontinuation rates often exceed 50%. And this is the second problem. So even if we can connect people to care, roughly half discontinue treatment within weeks. And this is the one that this project focuses on. So given that background, the goal of this project was to identify factors, both non-modifiable such as demographic characteristics and modifiable factors such as prescription characteristics that are associated with long-term buprenorphine engagement at the population level. And I've broken the methods down into 3 sections, starting with the first one. So first, we had to identify individuals who were starting buprenorphine treatment. And so to do this, we used the PDMP to identify all individuals who are initiating buprenorphine treatment for the first time. To do this, we pulled all buprenorphine prescriptions from the Rhode Island PDMP that were dispensed between July of 2016 and June of 2021. And we then identified all individuals who initiated buprenorphine treatment between July of 2017 and June of 2020. And this diagram just shows how we identified the buprenorphine initiates. So we used July 1st of 2016 to June 30th of 2017 as a washout period and excluded anyone who had any buprenorphine exposure during this time. We then identified individuals who initiated buprenorphine anytime between June 30th of 2017 and July 1st of 2020 and followed each individual for a year after initiation. And finally, we used the last year as a follow-up period for individuals who initiated buprenorphine treatment later in the window to ensure we had a 1-year follow-up for everyone. And these, for visualization purposes, I've just boxed off this, the data that would have been used in this mock situation. All right, so second, we then used the PDMP to determine if those individuals were engaged in long-term buprenorphine treatment. To do this, for each individual, we identified the day they started buprenorphine treatment and followed them for 12 months and extracted all buprenorphine prescriptions they filled during that time period. We then added up the day's supply of those prescriptions, and we defined individuals who were dispensed enough medication to cover at least 80% of the 12 months after starting as covered in long-term buprenorphine treatment. We then repeated this process again for a sensitivity analysis, just doing a 6-month follow-up. And historically, in Rhode Island, we've measured treatment engagement over time by continuous enrollment and receiving buprenorphine prescriptions from the PDMP with no more than a 7-day gap. But through manual review of some records, we found that this inappropriately categorized individuals who might be filling prescriptions early or filling prescriptions ahead of going on vacation would be marked as discontinuing treatment when they actually had enough day supply to cover them for the full time period. So we shifted our definition of long-term buprenorphine treatment engagement for this analysis because of that. So finally, having identified our population and our primary outcome, we look to identify factors associated with long-term buprenorphine treatment engagement. So our primary outcome was long-term buprenorphine engagement through 12 months with a sensitivity analysis looking at 6-month treatment engagement. We then sought to determine if any demographic or prescription characteristics were associated with long-term buprenorphine treatment. To do this, we performed bivariate logistic regressions with each of the predictor variables and included variables significant in our bivariate analyses in the final multivariable model. This was entirely exploratory and no variables were forced in. So for our results, so between July 1st, 2017 and June 30th of 2020, 4,898 unique Rhode Island residents initiated buprenorphine treatment per the Rhode Island PDMP. Overall, 44.8% had long-term buprenorphine engagement during the 6-month follow-up period, and 37.8% had long-term buprenorphine engagement during the 1-year follow-up period. Reflective of the opioid epidemic in Rhode Island, most buprenorphine initiates were male between the ages of 25 and 44 and were covered through either private health insurance or Medicaid. So overall, in our final model, we had 8 variables that were significant. The first 2 were age and sex. So we found that older individuals had a higher odds of having long-term buprenorphine engagement. And you can see in the table here for the adjusted odds ratio, the individuals age 18 to 24 extremely likely to not be engaged in long-term care. We also found that females compared to males had higher odds of having long-term buprenorphine engagement. When we looked at health insurance, we found that individuals who were on Medicaid when compared to private had higher odds of being in long-term buprenorphine treatment. And individuals who started on a higher day supply were also more likely to have long-term buprenorphine engagement. You can see starting with a 30 or more day supply compared to individuals who started on less than a 7-day supply. We also looked at distance. So we have individuals' home address and the address where they picked up their first prescription from the pharmacy. And we used zip code centroids to calculate distance between their home and the pharmacy. So individuals who lived further from the pharmacy were less likely to have long-term buprenorphine engagement. And individuals who started on the film formulation when compared to the tab had higher odds, with tab having a lower odds of long-term buprenorphine engagement. The final two variables we looked at were overlapping prescriptions. So we found that individuals who were dispensed an overlapping benzodiazepine were more likely to have long-term buprenorphine engagement when compared to individuals who didn't. And individuals who were dispensed an opioid for pain management during the follow-up period had lower odds of long-term buprenorphine engagement by quite a significant amount. Just out of curiosity, we also looked to see how some of these co-prescribing practices changed over time. And we found that the percentage of buprenorphine initiates given any opioid during the treatment window had remained relatively constant over time, with roughly 16% of buprenorphine initiates each year receiving an opioid during their treatment window, which was just defined as 12 months after their initiation date. Similarly, when we looked at the metric for co-prescribing buprenorphine and benzodiazepines, we found that the percentage of buprenorphine initiates with an overlapping benzodiazepine prescription had also remained relatively constant at around 17%. And this was defined for this analysis as at least 1 day of overlap between buprenorphine and a benzodiazepine prescription. The most controversial take-home message from this analysis by far was the advantages of co-prescribing buprenorphine and benzodiazepines, as the U.S. Food and Drug Administration issued a black box warning in 2016 advising against co-prescribing buprenorphine and benzodiazepines due to the increased risk of overdose. However, we believe based on these findings that healthcare professionals should reconsider and evaluate the benefits of increased treatment engagement versus the increased risk of harm. For context, from 2018 to 2020, among the 904 overdose deaths in Rhode Island, among Rhode Island residents, less than 5 individuals had an overlapping buprenorphine and benzodiazepine prescription at the time of death, and only 37 individuals were on buprenorphine at the time of death. This is incredibly promising given that each year during the study, there's roughly 7,500 individuals in treatment for buprenorphine. When we looked at the sensitivity analysis, all of the previous relationships remained unchanged, and all of the prior variables and associations were still significant in the final model. So we thought that there were 2 main takeaways from our analysis. The first was that removing barriers can help individuals be engaged in long-term treatment. The first barrier we found was distance, that individuals who were further from the pharmacy were less likely to be engaged in long-term treatment, and that by encouraging mail order prescriptions when possible for these individuals and ensuring the prescription was sent to a pharmacy close to their residence, we could increase treatment engagement. And second was day supply. As individuals dispensed a longer day supply were more likely to be engaged in long-term treatment. And this finding suggests that we could promote long-term treatment engagement by giving individuals a longer day supply so they don't have to return to the pharmacy as frequently. The other big takeaway message was on prescribing practices. And first was promoting the film formulation of buprenorphine and educating providers to start patients on the film formulation when possible. The second was to reevaluate the co-prescribing benzodiazepines and buprenorphine. And despite the increased risk of overdose, recognizing that management of symptoms and increased odds of successful treatment may be worth the slight increase in overdose risk. And finally, avoiding prescribing opioids during the treatment window and encouraging providers to check the PDMP and explore other options for pain management among patients receiving or who have recently received buprenorphine treatment for opioid use disorder. And this work was actually published, I think it was in December. So if anyone's interested, it's there, and I can send out these slides afterwards. In terms of future analyses, I'm currently working on a number of projects with actual alumni or current members of the COBRE. The first one looking at evaluating the impact of buprenorphine dose on long-term treatment engagement. The second project we're working on is evaluating the risk of overdose when individuals are on or off buprenorphine and how this changes by dose. And the third project we're doing is more of a deep dive looking at co-prescribing practices and looking at how receipt of benzodiazepines, stimulants, Z drugs, and opioids impact treatment engagement and overdose risk, and comparing how that varies by just receiving a prescription and having it overlap with their buprenorphine prescription. And that's all that I had today. Happy to answer any questions or talk about anything or potential future analytic ideas.
Ben, this is really great, and there's a lot of food for thought here. I guess one thing that jumped out is the well, you just summarized them all, but the longer prescription, that may be clinicians, if they feel that somebody's stable, they're doing well, then they'll prescribe a longer prescription. If they feel they're unstable, they'll give a shorter leash so they can keep a closer eye on them. Or they may have had problems with, they're unstable, they keep losing their script. You end up going to shorter scripts. Is there, but you can probably drill down on that and find out if there's like provider characteristics or patient characteristics that could either support or refute that. Because I think it would, if that is the real finding, that longer scripts are better, that would be helpful. There's a reluctance to do that among clinicians.
Oh, for sure. And the other thing that I couldn't control for is it is possible that some of these people were in inpatient treatment and then started on buprenorphine and then discharged, and therefore starting on a higher day supply, or individuals who were formerly incarcerated, getting out, maybe being stable, being on a higher day supply. So that's not their true initial dose, but we've been trying to look at different data sets. Unfortunately, the PDMP doesn't have a ton of other covariates that we can use, but I'm hopeful with some additional data, or maybe using hospital discharge data or other things, to get more details on the characteristics of the patients, to try to see if we can put them into different buckets or risk categories, as you're talking about.
So that's the other, you're just looking at the PDMP. It would be wonderful to have the data from the Department of Corrections, and also to have the data from the opioid treatment programs.
Oh, yeah.
Some of them are dispensing buprenorphine, and that doesn't get up into the PDMP. Is that right?
Yeah. So if they received it in person through direct observed therapy, then it wouldn't be in the PDMP. But we do have data sharing agreements with the Department of Corrections and BHCDH to get methadone treatment data, and I could get some buprenorphine treatment data from them. So we've done it before, doing a composite, looking at among people who had a fatal overdose, trying to get a composite treatment history, looking at PDMP and BHCDH, but I'd like to do it just for all individuals in general, and mapping out how individuals move back and forth between different treatment modalities in Rhode Island.
That would be very helpful, because somebody, and people do that, I think, fairly frequently. But first of all, just get a handle on the frequency of switching back and forth, which I think we have better access to buprenorphine than most states. To methadone. We have lower rates of buprenorphine prescribing than many places. So I think we're missing the boat there. The benzos is also kind of complicated, because it may be that the people that are more stable, you're more comfortable prescribing, co-prescribing to. So if somebody's really, so there's a selection bias there with both of those. Select for the ones that you can prescribe longer to, select for the ones that you can co-prescribe a benzo to because they're you're selecting the people that are more stable. Or maybe not. Maybe they are more stable because they're getting benzos and because they're getting a longer script. I don't know if anyone else has questions. I'm going to monopolize the time here.
Yeah, there's a couple other questions before Ian and then Ju. Just to respond, Jody, I think, one of the things we're working on, right, is trying to obtain data, electronic health record data from the OTPs. Kodak has expressed interest. And so that would really allow us to unpack some of those questions. And you can only ask so many questions with the PDMP because you have such limited covariate data. And so you can't really understand like confounding by indication. You can't control for all the things of why people might be on different doses, different lengths. It's just a hint that there's something there that then needs to either be supported by either more robust observational work or trials. Looks like Ian stepped away. Ju, do you want to go next?
Sure, thanks. Hi, Ben, good to see you again. And hi, Francesca. When I look at this, I think about, the topics that always come up: social determinants of health, housing, transportation, incarceration. And, the data that you have is very clinically oriented and limited to what is already collected. But I'm thinking it would be really interesting to see, the degree of housing stability or instability. If you have zip code data, you could definitely look at that over time. And even transportation, like the distance between someone's home and a OTP or a clinic or pharmacy is one variable, but another one could be, given that Rhode Island has a really extensive bus system, like overlaying somehow the map with the addresses or zip codes, like that could be a really interesting geographic analysis. Just wanted to put those ideas out there.
Yeah, we've just started to think about, because we have like all the ACS data by census tract, and the PDMP has exact address for everyone. So you could map it all back in. The downside would be we would just be applying, factors associated with their region and not them in specifically. But I still think it could be somewhat informative given how granular we could go. But here, I'm just writing some of these down for future projects when I have free time.
So I'm intrigued by those 37 deaths on people who are prescribed buprenorphine. Are you able to go back and look at the postmortem toxicology and find out if buprenorphine was actually present? Because a lot of them may not have it.
Ben, do you want to give a little teaser to the bupe overdose?
Yeah.
That you've been looking at?
So, and then I know Ian's had his hand up, so I'll go to him. But we've been looking at more recently among people on buprenorphine if they've had a non-fatal or fatal overdose. And the analysis is almost impossible because there's so few people who are in treatment at the time of overdose that we can't run many models because the counts are so low. And like for Rido, we have to suppress things if they're less than 5, and most counts, like if we're looking at different doses, are less than 5 individuals when we combine across multiple years who have had an overdose or non-fatal or fatal while on treatment, which is incredibly encouraging. But to answer your question, yes, for the fatal overdoses, we can look at both if it's present at the time of death and if it was a contributing cause to death. So we can definitely pull out the ones who had an active buprenorphine prescription and see how many.
Yeah. Great. I suspect that other category, whether it contributed to, I don't know what other, if there's not a bullet hole in the head, then they probably just use the concentration of buprenorphine And if it's high, they may say it contributed. But yeah. But that's great. That'd be interesting. Go ahead, Ian.
Hey, thanks, Ben, for that presentation and the study also. Two quick things. Number one, does the PDMP allow you to differentiate race? And the second question is, as you know, the methadone prescribers are most concerned about benzos being used also. Is there some difference between buprenorphine and methadone that makes the benzo co-prescribing more feasible, or less risky, whatever?
Yeah, I can answer the first question, then maybe I'll refer to a clinician for the second question. Unfortunately, the PDMP does not collect race or ethnicity information. We have provided PDMP data for buprenorphine to EOHHS, who is composing a composite race ethnicity file using all the available state data sources. And when we've done that on PORI, there's the rates of methadone receipt by race ethnicity, which non-Hispanic whites having almost double the rate of methadone compared to non-Hispanic Black and Hispanic. And the buprenorphine one is almost identical. Like if you change the titles, you wouldn't even know that it was different data. But unfortunately, we can't export identifiable data from EOHHS, so I haven't been able to incorporate it into other analyses yet, but I am working on trying to get it.
Great, thanks.
That is a major public health disaster within this disaster. Is that, you know, this is our main treatment, and we're not giving it to Blacks and Hispanics. It's absurd. So some of that is access, some of that is, you know, cultural and family support, and some of that is, you know, probably just the way people are treated when they do access treatment. But we've got to fix that right away if we can. I think that the rates at the Department of Correction have been more equitable. So that implies that it's not, you know, that it's really access, because everybody gets offered treatment at the ACI. And if there was some cultural reason why people didn't want you know, to get treatment, they wouldn't accept it there. I haven't seen good data on the retention, or at least not that I can recall. But I think that needs to have a lot of focus right now.
I'm going to jump in with a couple questions. One, just super clarifying, and also to say that was really great. And it's fun to see these data coming to light, and with the attention that it really deserves to explore and understand buprenorphine a lot better and PDMP data. But one question I had was just to partial edification of this conversation, but that buprenorphine that is dispensed through OTPs like Kodak or major other OTP locations are not reporting into the PDMP. Is that correct? So unless they send their patient to fill at a community pharmacy, if the OTP is dispensing, it wouldn't be in the PDMP.
I can get more details, but a lot of them have like internal pharmacies, and then they're still reporting it all to the PDMP. And so like, even if someone fills it like within the hospital, or they have like their own pharmacies and they're still reporting. I could try to do a deep dive. I know like medication that is given for patients to take during the visit is not required, but any take-home medication for any patient that's controlled should be included in the PDMP, with the exception of methadone.
So that may be a really interesting, I mean, it may be that because, you know, methadone clinics don't report to PDMPs, period, that you may be missing the data, which could be an interesting thing to explore and sort of estimate how much you're missing, because we have a lot of different demographics that go to a methadone program that are getting buprenorphine through that pathway versus to a primary care clinician or other, medical doctor pathway that go to and fill a pharmacy fill, obviously, but that might be interesting. But it kind of is related to my question, and maybe just sort of area maybe of other area of interest and exploration might be to turn the data to the prescriber side too, because the PDMP does have prescriber level data. You have the DEA of that individual, you have where they're practicing, but it may be, if you do have OTP dispensed buprenorphine, you can consider that OTP as a prescriber too, which should be interesting to see what proportion, or is there a role for longer retention in OTP derived buprenorphine dispensing and care versus primary care versus, so looking at the type of provider and the space where they're kind of, where are we contacting patients where and helping to retain them, such that we might see some provider level factors or prescriber level factors that could help us see. And this isn't sort of like who gets the gold star, but more of like, where do we need help and where are things going along to just, let it ride. But that might be interesting just to look at like prescribing of like 30-day fills from the start, or or maybe administrative discharge, for instance. That's a big thing that we worry about, like when things are stopping too quickly. Anyway, but those sort of patterns at the prescriber level. But my question was about naloxone. And I was curious, because we uniquely have PDMP data, naloxone, if any of the naloxone fill data were, what did that look like for folks retain at 6 and 12 months? And was that a factor at all? Was being prescribed naloxone or filling for naloxone important to retention, or even important to that benzo buprenorphine, is risk being mitigated at this time through this pathway?
Yeah. Two comments. First, I'll talk about the provider. So in the PDMP, we have the provider's name, which generally includes their degree as part of the name. But outside of that, and the DEA number and their NPI number, we actually don't have that much information. We have a ton of information on the pharmacy that they picked it up, the exact address. But in the PDMP, the address of the provider who prescribed it is not present. So if anyone knows a way to get it, we have been linking to the medical license data because it has the exact address for every provider in Rhode Island, but providers are only allowed to list one address, and they don't change it when they like re-up their license. So whenever they first got their medical degree. So we were looking up providers and then finding that they might no longer be at that location or be practicing at 3 or 4 locations, because we were trying to see like how distance to provider played a role and if we could map that out to promote access. But it's been,
that may just be provider type. I see that you might be able to look at like NP versus a specialty of the medical provider, but you might be able to derive from the pharmacy if the location of dispensing is like a Kodak site versus a non-Kodak, like their known sites. I'm just saying Kodak for an example, but any of the other OTP pharmacy locations are clear. It's just a list of 10 or whatever. But that's cool.
For sure, I can definitely look at that. I hadn't looked at it yet. We've done it for other analyses, but not for this one. For the question on buprenorphine and naloxone co-prescribing, haven't looked at it yet. In general, we know that among people who have had a fatal overdose, it's roughly 10% have filled a naloxone prescription. But we'll see what happens. I think going forward, we may. This is totally unrelated. We're considering stopping recording naloxone in the PDMP, given that over-the-counter naloxone will be available and that they could buy it versus getting, putting less barriers in place so it'd be easier for people to get it, given how few people, it seems, who are high risk are using the PDMP to get naloxone or getting a standing order prescription that's recorded in the PDMP. So we'll see how that goes, but I can look at it for at least now to see how many people. It's tough because I feel like we constantly get asked to evaluate the co-prescribing regulations, but as you know, the PDMP only has dispensed medication and not prescribed. So it's difficult to know how many people are actually offered it when they start treatment or fill an opioid prescription. But
it would be neat if there was a role though in retention for being, the act of having the conversation, prescribing, or at least, some aspect of that, but yeah,
I can definitely look at it though.
it seems a little silly at this point in the epidemic when, we identified in 2015 that we need to, get people on medications that we still can't really find, it sounds like you don't have easy access to the correctional database and the OTP database. But that should be something we are tracking and drilling down on and acting on, monthly, rather than just come at it a few years later and kind of, well, we got incomplete data. Ju, you got something? I can't read that fast. Tell us what you're saying.
Oh, I was just wanting to mention that we could consider like surveying opioid prescribers. I just shared a paper that talks about that in Maryland. And I also wanted to mention, I think Ian's question still hasn't been answered.
Which one? The
difference between so the partial agonist aspect
Oh,
of
yes.
buprenorphine is highly helpful for overdose prevention,
yeah,
period. The partial agonist aspect of buprenorphine is helpful for overdose prevention, period. You add whatever you want to add on that doesn't potentiate the opioid in the same way because it's a partial agonist. Anything that's a full agonist like methadone or OxyContin or oxycodone or hydromorphone, or like you pick the other opioids, different kind of actions, but the benzo potentiates all of that. I'm saying this as an epidemiologist, not as a pharmacologist, not as a medical doctor, but as an epidemiologist with a public health hat. But like, as someone who's involved in that black box warning, I was like, why are we putting bupe in this box? Because it's very different. And like all things, it ends up, the data are not totally clear. It's still low. The risk isn't minimal. It's not zero because it's still a partial agonist. But you look at the data and you're like, we don't even have enough cases to run a chi-square on this, let alone a model. The reality is that it's extremely safe and helpful medication combination that still does a lot for a lot of people, but we should still always look for safety. But
Tracy, just to
Francesca, maybe others-
piggyback, no, I was going to piggyback. I totally agree with that comment, and I hope that we aim to debunk a little bit of that with this analysis that Ben is carrying out. So basically looking at, the entire, like all bupe initiators in the PDMP is like a long cohort, and letting all of their time contribute so that we, in theory, know at least someone's got like buprenorphine supply in hand on a given day. And like overdose is a discrete event. And so you can actually like map like what's happening on the day. Should they have been on bupe? Did they overdose? And I think what we're going to see is exactly what you're saying, is that like when people have access to buprenorphine, the risk of overdose and occurrences of overdose, I think, are going to be really, really tiny. And the overdoses are going to be occurring when there's those like gaps in care. And so that we can kind of like debunk this, like, and looking at doses is like different exposure levels. Because I think that thinking still, like, I still hear it, right? Like worrying about increased overdose risk.
Thanks for that distinction, Tracy. That'd be a really good piece of information to get out there, because I know there's a lot of misunderstanding around it.
It would also be very useful to look at these 37 bupe prescribed, or any deaths with buprenorphine is found in the body, to see if the very high levels correlate. And I haven't seen any. I think I think there's been so few of them, but I think there's a sense that we should be prescribing higher doses of bupe now because of fentanyl, and but I've heard some clinicians are reluctant to, because the standards have been 8 to 16 rather than going right to 24.
Yeah, and I'm hopeful the work I'm doing with Francesco will provide some light on that. We have a couple of things pending publication that aren't out yet, but hopefully we can share those as soon as they're available that will promote the higher doses and the safety of higher doses.
You're lucky you get to work with Francesca.
I know, very fortunate.
Those you, Jody, maybe not.
Everybody wants to work with Francesca. So I'm not sure I caught all what you were saying about the co-prescribing of opioids. That was problematic, was it?
For that one, we didn't do co-prescribing. We just said if they had received any opioid prescription during the follow-up window. And I was just shocked at, I'm not a clinician, so I thought the percentage would be lower, but that 15% of people who started on buprenorphine for MAT within 6 to 12 months got an opioid prescription for pain management. But yeah, I guess exploring other pain options for those individuals.
Yeah, well, it's hard to know exactly what's going on there. I mean, sometimes if somebody, breaks a bone or has an acute pain episode, you could, we used to, like, if somebody's going to surgery, you have to wean them off the buprenorphine, then transition them over to opioid agonists, and then you have to wean them off the opioid agonists to get them to back onto buprenorphine. And now I think there's a greater appreciation that you can just leave people on the buprenorphine, add whatever you need to add to deal with the acute pain, and then take it off when you need to take it off. And the buprenorphine is just there, so you don't have to go through that. Getting someone back onto buprenorphine, they're on it the whole time. You just have to probably give a higher dose of the opioid. And also, depending on the pain, increasing the buprenorphine dose can help. But it's hard to go from that and to jump and say, oh well, people shouldn't be getting opioid prescriptions. It might be worth looking at the. Maybe that's a sign of. Actually, do you have data? You could maybe look to see if the prescriber ever actually checked the PDMP, because they have logons, right?
I've tried, but it's like in a separate data system, and it's like incredibly difficult. And we can see if people have checked the PDMP. I can't figure out yet their search history for what patients they had searched for, to see if there's a direct correlation between logons versus, for the patient that they did.
Yeah.
But yeah, I'm definitely interested in that, because even I'm talking out of my wheel of expertise, but the required number of logons that there should be based on regulation versus what there is lower. It's also tough because a lot of people have work in medical systems that have it integrated into the medical record, and it's like, I don't think it's possible to check those providers.
Yeah.
You might be able to get it from the vendor.
Oh yeah, that's what. Oh, you mean like from the medical record?
The request, yeah.
We get it right now from APRIS, who manages the PDMP interface for clinicians to log into. But yeah, I haven't figured out a way to. Maybe I'll see if we can get it from medical record vendors. Ian?
Yeah, regarding the OTPs and the PDMP, I believe that in the past 42 CFR Part 2 prohibited the OTPs from reporting to the PDMP, but I believe that the latest revision relaxes that requirement. So that might have been a barrier in the past. I don't know that it is now.
When I first started, we had presented opioid treatment data for people who died of a fatal overdose, and we included methadone, and I received a lot of passionate emails about resistance to including methadone in the PDMP, and I think part for patient confidentiality and part for the fact that doses can change daily and it would be a lot of burden to report it. We do have a data sharing agreement with PHCDH though, so I can get overall treatment data for people, and we've been able to get that a few times. But we don't get the daily doses and daily variations. But hopefully, as Francesca mentioned, we're working with Kodak to try to set up an agreement where we could get daily doses of methadone and then map how people change from methadone to buprenorphine and how different dose like ramp ups or maintenance contribute to retention and care, which would be really exciting.
Yeah, I think that one of the other objections was the reality or perception that law enforcement has easy access to the PDMP, even without subpoenas, whatever.
Yeah, and I think with the new regulation change in January 1st of 2023, it used to be that law enforcement could request PDMP records, and now it's almost virtually impossible for them to get it. Has to be like specifically court ordered, and there's like all these requirements, and it's virtually inaccessible, which I think would lessen that concern.
Oh, good.
I wonder if it's worth repeating this same analysis, just PDMP data in another state. What if you could find one of your counterparts? Because if the findings are similar, that might make them more robust. And if you can, look at, correlations. So
That's
to make
interesting,
it,
Jody. I'm thinking too, as you're saying, other states like, the geographic, like distance to pharmacy and things like that, and particularly like rural areas might be interesting.
yeah. But obviously, it would be great if we had access to all this other data, but we have the PDMP. And so if we could interpret what that means on a sort of macro level. But I mean, I'd like to know, we should do a major intervention to get Black and Hispanic people enrolled on methadone and buprenorphine and retained in care. And then, monitor, you can monitor that in almost real time. Like if you see that, if we had the race, which is a big if. Race, ethnicity. Just trying to think of ways to make this a more useful data set.
Yeah, that the race ethnicity piece is such a glaring, awful mess. It really is, like, considering we haven't been able to come up with a way to appropriately do this across state survey data through PDMP. It's like, oh goodness, how do we appropriately address our inequity and without the data to be able, we see it in little blips, but not enough to have an approach. So I applaud the whole state for trying really hard to come together and find ways. And even with bringing in like ACS data, or thinking like, okay, maybe at the census block, we could maybe see the proportion of Hispanic Latinx individuals in this community where the medication was dispensed or where the individual lives. Like, we'll get close to it to approximate it, but we really need patient level data to see what we're harming and what we're helping. But maybe you'll see something as you bring those together too.
I mean, some communities, there's a problem with the pharmacies not stocking buprenorphine. I don't think we have that problem in Rhode Island. That's because if it's not your local pharmacy, just go next door. But I'm thinking about communities that are one race or ethnicity or another. If the pharmacies in there don't stock them, that could be a problem.
I'm wondering if at the next or future COBRA seminar could invite like a researcher from somewhere in Rhode Island or a neighboring state who specializes in engaging these populations into OTP and buprenorphine. It might be worthwhile to have some additional expertise.
Well, the Imani project is supposedly trying to do that with the Black churches. And they have been doing it in Connecticut for a while and started here about a year ago, I think. So it might be good to get an update from them. We can get Akosha Dankwa to,
Actually, that they had their first training last weekend, so it's just started.
okay.
Oh, that's great.
Awesome.
Yeah, so that would be great to track on the PDMP if we could get race ethnicity. I think probably Connect Care should have race ethnicity data. You aware of that, Ben?
I've heard it before, but I haven't explored getting it yet. I also know like the health department's considering making a data lake with different sources and things like COVID testing and COVID vaccines, which are generally self-reported race ethnicity for most of the state. Could
Oh,
be
great.
helpful, but and I just wanted to loop back. I know for this paper we did time distance from home to pharmacy just based on zip code centroids because it was a crude estimate, but relatively easy to do in SAS. There is ways to do it in ArcGIS where you can get drive time between two locations, and I could do that, which would be much more sensitive and
Yeah.
further explore how that's a barrier.
Well, drive time is fine if you have a way to drive. But Drew's idea of overlaying it with the transit routes might be helpful as well. I don't know if ArcGIS can do that. I think Google can do that.
Yep, that's what I use if I have to catch a bus in Rhode Island.
The other thing, Ben, I'm not sure if there's any, I mean, it's like the housing piece is such an important fundamental for just our statewide strategy, but also just like for patients to manage medication, hold medication, feel safe with their medication. And I don't know if there's any way to get housing data into, as a possible merge point, but or if there are other places within, if there are other health department data sets, COVID related data sets or otherwise that might be able to provide housing status indicators, but that would be.
We have linked before and got data from HMIS and got information on all housing and secure individuals. The only, and we found that I think among fatal and non-fatal, it was roughly 15% of people had an overdose who were, housing unstable, which given the population size was like a dramatic percentage of the population that had an overdose relative to the rest of the population. The only concern that we had was that we know it's relatively difficult to get housing services and that it would probably be, we didn't want to be vastly undercounting the burden. When we did like just a narrative search in some of the medical records, we were able to identify a lot of additional people who had unhoused or homeless in their medical narrative, but weren't showing up in the HMIS data set. And so we didn't want to minimize the burden among individuals who are housing insecure because it was so difficult to show up in the HMIS data set, given that we could easily identify many more people who weren't present. But it is something that we're trying to do, but it's not like we're exploring different strategies, but I haven't found like a really good way to do it yet.
No, I wish that some of the HUD data sets that kind of have a little bit more like the kinds of housing, just thinking like things like installing harm reduction vending machines or better placement of messaging around buprenorphine and induction programming, or like something that could allow for a little bit more connecting of services, low barrier services and access points, and so that people can get efficiently to care or supplies. But it's hard to know. It's like that like the large blob of like people are housed, they're in their home when they die, or they're in their home when they're taking medication. But there's so much about the home that we don't need to peel apart. But
we are exploring a little bit. So for the fatal data, we have tons of information in suitors on like housing status that they're unhoused. So we're starting to make heat maps of overdose burden based on specific characteristics. So like we just made some because of the increase in deaths in Hispanics, making heat maps for communities by race and ethnicity. So if groups are targeting specific populations, they'll have more detail because the hotspots don't seem to overlap. They're like distinct areas to allow for more targeted outreach. But I think the sample size would be quite low, but that could be another way to look at individuals who are housing insecure to see if there's any hotspots that we could identify. But yeah, I wish it was easier to get data. It's unfortunate how we have it. I feel like we have the best data at the state for the people at the lowest burden. So
Well, you're doing a lot with what you have, so it's really amazing. And thank you for coming to share everything with us today.
no problem. Thanks for having me. And I got 10 new research ideas, so maybe it'll be
Right on. We know where to find us all, and new friends here. And
Yeah. Reach out anytime. Great.
Thank you, everybody, and thanks for everyone who stuck with us for the conversation.
All right. See you next time.
Thanks. Bye, everybody.
Thank
Bye.
you, Dr. Bodwin and Hallowell.